Good afternoon, everybody. If we could have you get to your tables, we'll go ahead and get started in just another minute. All right, so I think we'll go ahead and get started. Helen and I were sort of reflecting the other day about sort of when the last time we did this was, and it was in the fall of 2019, which was 5 years ago. It's hard to believe it's been that long, and I'm sorry that it's been that long, but we finally have gotten permission from the Stanford powers that be to get everybody together in a room again. There still are some restrictions in terms of food and stuff, so it's not the buffet that you're used to. But again, I hope we can kind of persevere through some of that. It's just great to see everybody in the same room, not in the clinic buildings, and everyone's sort of enjoying each other and catching up a little bit as well. A couple of housekeeping things before we get started. So we are video recording this. It's not simulcast, so it's not live anywhere, but we're hoping to have the video of this available afterwards. We'll have to kind of let you guys know through the PFAC and other routes when it'll be available to be viewed. As you notice, we also have a photographer here tonight, and we may use some of this for the website, which I'll talk about a little bit later. And so if we're going to do that, we ask if you guys could sign permission slips out front to do that. So if you can remember when we kind of take a break and go out there, if you can sign the permission slip that says it's okay for us to use you in the photo. We'll go through all the photos, and if we don't have your signature, we won't use your photo. But if you could do that, that'd be great. And then we're also going to take a big group photo as well. So please make sure you kind of keep an eye out for when we're going to get that group of you together to take those photos moving forward. With that, I think we'll just jump right in. So our first speaker is Jack O'Sullivan. I've known Jack now for a couple of years. He's currently a fellow here at Stanford. As you'll soon hear, he's from Australia, and he comes to us from a PhD in computational epidemiology at the University of Oxford. So he's very, very smart, probably smarter than most of the people that I know. Then he did a T32 postdoc fellowship with you and Ashley. And then after that, he did his clinical training at Stanford. He did internal medicine at Stanford. And then he's doing a cardiology fellowship, for which he sort of fast-tracked into a sort of a research career. So his research focuses, as you can see, on things like genetics and epidemiology and advanced machine learning and statistics. And also he has an interest in surfing, which I don't know, like everybody from Australia has to have an interest in surfing. I think it sort of comes with the territory, I guess. But Jack's gonna be talking today about medical AI, promise, pitfalls, and prediction. Jack, take it away, thanks.
Thank you very much, Dr. Tudeberg. Can you all hear me okay? Yeah. Fantastic. Well, thank you all very much for being here. Thank you for the patients, the family member, and the faculty member. Artificial intelligence is really everywhere in our world. It's changing our lives. I suspect that most of you have used things like ChatGPT. Maybe some of the more adventurous of you have used driverless cars. And perhaps some of you in your day-to-day life are using automated virtual assistants such as Siri. But how does this technology help us in medicine? How does it help us as doctors, as cardiologists, and you as patients? I want to start with what artificial intelligence can already do in medicine. And I'll start with this simple test that I'm sure many of you have had, the ECG, the electrocardiogram. For those of you that don't know, this is an electrical representation of the heart. The black lines is the electricity of the heart. Now, we use this to diagnose a handful of cardiac conditions. What artificial intelligence can do is it can read an ECG. Now, what do I mean by read an ECG? Well, it can see the things that we can see. It can see the P wave, it can see the QRS, and it can see the T wave. That in itself is probably not that helpful for us. That's something we can do reasonably well, but they can do it in an automated way. But what do I mean by read beyond that? Well, beyond digesting those signals, we found that ECGs can also understand these signals and predict disease. So it probably won't be surprising to any of you to know that from an ECG, artificial intelligence can predict a handful, an array of cardiac diseases with an accuracy of about 83%. But we were certainly surprised when we found that these ECGs can also, with reasonable accuracy, predict a host of non-cardiac, non-heart conditions. So this ranging from lung conditions, liver conditions, kidney conditions. They can even predict if you've had a transplant before. So we know that artificial intelligence can read and digest ECGs. What about more complicated data? I'm sure many of you have seen an echocardiogram before, an ultrasound of the heart. This is an example of one right here. Measures the contraction and the relaxation of the heart. What many of you probably don't know is after we spend 30 minutes getting those images, someone like myself through my training goes through and marks out all of these borders. We mark out where the heart muscle is, where the cardiac volumes are. That manual process takes about 30 minutes or 45 minutes. That helps us get really essential metrics of your heart function, things like ejection fraction, the percentage of blood that is beaten out through each cardiac cycle. Now, what can artificial intelligence do? Well, it can do this automatically and instantly. You'll see here that the markings, the blue volume of the heart is automatically tracing the volume of the heart, and it's following that through the cardiac cycle. So that takes me out of a job, saves us 45 minutes, and automatically assesses the ejection fraction. You can see the top part of the heart's not pumping as well as it could there, and the bottom part is a normal cardiac function. All right, so we know that artificial intelligence can read and digest ECGs, and it can trace the borders of hearts on echocardiograms. But can we take that one step further? The answer is, it looks like we can. So this is an artificial intelligence model that digests all the ultrasound images of your heart. You'll see them up in the middle there. Without any human supervision, it digests all of these and then produces a report, the text report of the echocardiogram. You've probably all seen echocardiogram reports. They come in your My Health. They require someone going through these images manually and then writing a report that looks something like this. Normal left ventricular ejection fraction, normal LV size. So the technology has progressed that we can now do that automatically and almost instantly. But we still wanted to take this one step further. You don't go to clinic, you don't see someone like Dr. Teuteberg, you don't see him just to read out the results of your echocardiogram or your ECG. You come to see him to make an overall assessment of your health. You go to a cardiologist to make a diagnosis, to make a plan for your health. So we wanted to take this one step further, to go from reading data to making an overall clinical assessment. And I want to talk on some of my work with one of my mentors, you and Ashley, one of the cardiologists here as well. We tried to set up an experiment to test this. Can artificial intelligence make a clinical assessment for cardiac patients? So what did we do? Well, we inputted to the model similar data to what I just described: ECGs, echocardiograms, cardiac MRIs, and where appropriate, genetic tests. And we asked it to try and generate something like this. What's the diagnosis? How sick is this patient? What tests do you need to do? What management would you recommend? Now, how do we evaluate how good the artificial intelligence was? Well, we ran a paired parallel experiment. So for about 200 patients, we gave our artificial intelligence software all the results from cardiac MRIs, Zio patches, ECGs, echocardiograms, and asked it to make an assessment. For the same patients, we asked cardiologists outside in the community, nothing to do with Stanford, to make the same assessments. So the model did that reasonably quickly. We had to wait a couple of months while the cardiologist filled in the blanks for us. But at the end of the day, we had 2 assessments for the same patients. We gave this to some of our subspecialists cardiologists here at Stanford and said, which of these two assessments do you prefer? We didn't tell them which one was which. We asked them to rank them overall, and across all of those domains I described, diagnosis, management. So this is what we found. We found that considering the entire response, you'll see the red bar is when our artificial intelligence, our model, which we're calling AMIE, A-M-I-E, was preferred. You'll see in the blue is when the cardiologist was preferred, and then a tie. So you'll see overall, it was marginally, modestly preferred, the artificial intelligence. We called this a draw. We didn't want to be getting too far ahead of ourselves. But overall, we think it did it as well. And across all of these domains, specifically looking at diagnosis, how sick is this patient? What are the next steps? It did as well, if not better, than the general cardiologist. Now, we hypothesize, and the data supports, an integrated method. We don't think one of these approaches, just using AI or just seeing a cardiologist, is going to be better than another. So we wanted to test actually what happens when we give the cardiologist that information that was generated by our artificial intelligence software. So that's what we did. We said, here, this is for that same patient you just gave us an assessment about. This is what artificial intelligence thought. Have a look at this, then review your answers. If you want to change them, send them back to us. And then we went through the same process of a blind Stanford cardiologist determining which of those two responses they prefer, the cardiologist or the cardiologist with some help from artificial intelligence. And what we found again is, considering the entire response, about 65% of the time, the combined responses were preferred. A lot of the time, these were small things, but there were a lot of reminders. There's a lot of things to think about when you're seeing a patient. The artificial intelligence model would say, oh, don't forget about family history. Don't forget to ask if someone's passed out. We found that really improved the responses. So I want to take you through a use case of this. We extended these results and said, okay, you're a cardiologist in the community. You're a cardiologist that doesn't have cardiologists such as Dr. Tuderberg, experts around to run these cases by. You've got a complex patient. Can our software help you? And I want to run through a conversation that we simulated that's in our paper. So pretend the blue is a general cardiologist. And the cardiologist says, I've just seen this 69-year-old that I'm concerned about. Can I run these past you? And then our AI, always happy as well. You know, other cardiologists aren't always happy, but AI is always happy to help. I said, no problems, no problems. And then the cardiologist says, all right, well, I've got this ASH, this asymmetric septal hypertrophy, and SAM, systolic anterior motion of the mitral valve, and this LVOT gradient, this ejection fraction is 71%. What do you make of this? And AI says straight away, well, that's pretty suspicious for this disease called hypertrophic cardiomyopathy. Now, the cardiologist, you know, it's a rare disease, but might be familiar with it. And they say, well, hold on a minute. This gradient, this blockage that the thickening is creating, it's pretty minimal. The patient's actually asymptomatic. Does that change how you think about this case? And the artificial intelligence, with the world's literature at its fingertips, said, well, actually, if you look at all the evidence, that mild obstruction doesn't change how I feel about the diagnosis. And these patients can be asymptomatic. It also reminds the cardiologist to say, don't forget to think about the Holter monitor. Don't forget to think about the Zio patch. Then lastly, it says, and also don't forget to think about some other diseases. So just reminding cardiologists that it could represent another disease, not just hypertrophic cardiomyopathy. So that was an example of a conversation helping through the diagnosis. The conversation then continues, focus a little bit on management. So the cardiologist says, okay, what do you recommend? Now, we know a lot of patients out in the community don't get genetic testing. We know it's a class 1 indication for conditions like this. So the artificial intelligence says, well, don't forget about genetic testing. Don't forget about a cardiac MRI. Now, the cardiologist, not to be completely outshone by the artificial intelligence, says, well, what about sudden cardiac death? What about family history? The artificial intelligence said, yep, good idea. Specifically ask about these three things. It then goes on to talk a little bit about tests we can use and then medications that we can give. So that's an example of how we think artificial intelligence can provide support to cardiologists out in the community that don't have the privilege of having esteemed colleagues around. We think it could even be extended to non-cardiologists. You know, a lot of these patients see primary care doctors for the first time. And then we think that actually this software could help patients as well. And I want to take you through a conversation between a patient and this software. And I think it's important to note that this is still provisional and we wouldn't let this loose just yet. But bear with me as I take you through this 63-year-old woman who went to her primary care doctor, actually, unfortunately, after her brother suddenly passed away. The primary care doctor very appropriately referred her to a general cardiologist and then ordered an echocardiogram and a Zyno patch. Now, as I'm sure many of you are aware, it's a long wait to see a cardiologist. The echo report result came back. You can see it on the screen. And maybe some of you who have been around for a while and pretty aware of your own heart health are familiar with it, but she was pretty overwhelmed by this. So she can turn to artificial intelligence to try and help her through digesting what this ultrasound means. So she asked, I'm pretty overwhelmed. What does all this mean? And then the artificial intelligence, again, always empathetic, unlike the cardiologist. Most of the time we do well, but always empathetic. And it says, look, it zones in and says, this is abnormal. And the main abnormality is this asymmetric ventricular hypertrophy. Then she says, well, what does that mean? Then it goes on to explain in, I think, pretty reasonable lay terminology exactly what this is. Thickening of the heart can sometimes obstruct some of the blood. Actually, the conversation goes on to then explain what that obstruction is and ultimately points the patient towards a diagnosis. We hope this could potentially help this patient be seen by a cardiologist quicker. Now, what have we covered? We've covered artificial intelligence and its role in reading, digesting, and predicting from ECGs. We've also covered artificial intelligence and its role in digesting echocardiograms. What about artificial intelligence in heart transplants? Now, there's a lot of emerging evidence about how artificial intelligence can match donor hearts to patients quicker, how they can predict outcomes post-transplant. But in my opinion, that evidence is not strong enough yet to present here. I want to focus on actually what artificial intelligence can do to reduce heart transplants. And what I want to focus on is a disease we've already heard about, which is hypertrophic cardiomyopathy, a genetic condition, thickening of the heart, predisposes to heart failure and dangerous arrhythmias that can be life-threatening. Before we go any further, I want to take a step back into my former life. In Oxford, I used to row. And I always think about rowing when we were thinking about digesting and explaining how the heart pumps. And I'll admit this is borrowed from you and Ashley. I think borrowed it from a Scottish professor from the 1960s. But if you think about an oar locking into the water and then that rower pushing that water forward, that's how I think about the molecular process of the heart. So if you think about and look at this orange protein that I've circled and then that green protein that I've circled, through every contraction, they link together like an oar into the water, and then they push and they shorten. Now, you'll probably also notice this blue protein, myosin binding protein C. And I think about that as the cox, the rowing cox. It's the protein that says, okay, you've been contracting long enough, stop and relax now. Now, you probably know that a dysfunction, a genetic variant in this protein leads for this protein to be dysfunctional, essentially not exist in this apparatus. And that leads to the lack of cox in the rowing machine. the rowing boat. And then that leads to the heart working too hard, contracting too much. And that's one of the ways you can end up with hypertrophic cardiomyopathy. So to summarize, no COX, no myosin binding protein C, too much contraction. Now, how is artificial intelligence helping this condition? Well, to put it simply, if you're missing that gene, if you're missing that protein, we want to try and give it back to you. The challenge in doing that is coming up with a device, a capsule, that can transport this gene to the heart, so it needs directions, and then go through the body and not be detected, not alert your immune system to destroy it. So it needs a capsule to contain this protein, this new gene. And that's how artificial intelligence is helping to reduce the burden to try and cure, potentially, hypertrophic cardiomyopathy. It's creating the capsules that these genes go within that then transport to the heart to reverse that condition. And there's ongoing clinical trials. The early evidence is dramatically reducing the thickness of the heart. Now, the next thing I'd like to talk about is potential pitfalls. We've talked a lot about the potential of artificial intelligence, but there remains significant limitations. The one I want to highlight initially is the potential for artificial intelligence to worsen existing inequalities in our society. There's emerging evidence that artificial intelligence can predispose bias against gender, race, and minority groups. And one of the ways to get around that is more inclusive and diverse data. That leads me to the second pitfall, the second limitation that we need to be incredibly vigilant with. And that's about data security. With more data, we need to make sure that all data is secure. You've probably heard about 23andMe being on the brink of collapse. They have millions of genetic data, and rest assured it is all completely de-identified. But there's some concern about where that data goes if the company goes bust. I'll reassure that at Stanford, we take absolutely every measure and don't share that data. So to summarize, what have I hoped to get across to you today? Well, that artificial intelligence can read ECGs and echoes. It can generate clinical assessments, can guide gene therapy to hopefully reduce heart transplants. And there's some very important pitfalls that we need to be aware of and continually work on before we move forward. I wanted to close with something non-medical, just for fun. As Jeff mentioned, I did my PhD at Oxford, and I was friends with a lot of ancient historians. One of the issues that ancient historians have is their data is completely static and often destroyed. This is an ancient Greek scripture. You'll see that basically half of it is blank. So historians for hundreds of years have argued about what goes in those blank parts of the scripture. Now, what's been pretty exciting, while we're here trying to predict the future for our patients, there's researchers back at my old institution at Oxford that are trying to fill in these gaps. They use the existing literature to build a model to try and predict the gaps in those scriptures. And of course, we'll never know, we'll never really know, but they got together a group of very smart ancient historians and thought that their response was reasonable. And they published this in a journal called Nature, probably one of the most high impact journals. So I found that as a really fascinating application and pretty different to what we're trying to do, but they are using the same tools. So I thought I'd leave you with that. And I just wanted to say thank you very much for my mentor, you and Ashley, and both to Dr. Teuteberg and Helen for the very kind introduction and invitation.
Thanks, Jack. Amazing stuff. So, I mean, I think that something that knows everything, is empathetic, and is always on time. I think the physicians are in real trouble moving forward if this AI thing catches on. But no, I mean, I think it's fantastic. And maybe I can just take a quick poll, because I think that sort of democratizing the delivery of heart failure care and maybe diagnosis is one of the more powerful things about this. There's not many heart failure doctors around out there, and it takes a while sometimes for you to kind of wend your way through the medical system to end up at a place like Stanford or, you know, another transplant center. And maybe I just can take a poll for the people here, like how much time was between your diagnosis of you having heart failure and you seeing us being referred in? Was it more than 6 months? Just raise your hand. Yeah. And so I'm hoping that, and you know, to Jack's point, because there's a lot of things we can still do when, even when the disease state is in its, you know, very symptomatic stages, that we may be able to delay transplant or even preclude it altogether. So I think this is super exciting. And, you know, I think we're at the real epicenter of some of this learning, as long as the AI doesn't sort of take us up and digest us into something else and take over the world, as we've seen in many scary movies over the years. But I think we're going to move to the next speaker, and we're going from sort of technology to psychology. We kind of cover the whole gamut here. So our next speaker is Katie Sears Edwards, and she's a psychologist and a clinical assistant professor at Stanford, and she works very closely with the CVI. We're very lucky to have her and her colleagues here. She's the director of our cardiac behavioral medicine service, which really specializes in using evidence-based behavioral medicine techniques to address things like adjustment and medical adherence and all the sorts of things that go along with having cardiovascular disease. And her clinical work involves both one-on-one care and group care. And she's going to talk to you a little bit today about resilience surrounding heart transplant, strategies to cope with anxiety, adjustment, and existential concerns. Katie, thanks so much for being here.
Thank you. And okay. Hello. Hi, can you guys hear me? Yes, hello. It's so nice to be here. Thank you so much for inviting me. So I want to start off by letting you know that heart transplant is not my specialty area. So it's really a little bit ironic to me that I'm in a room giving a talk about transplant to a lot of people who know a lot more about transplant than I do, but I'm going to do my best. And I wanted to tell you a little bit about my history also here at Stanford. So I was hired first within the Women's Heart Health Clinic, and I spent probably my first 8 or 9 years specializing in women's heart health. Along the way, my program grew. All the different cardiac clinics realized it might be nice to refer patients to a psychologist. So I started learning about all kinds of different cardiac problems. And along the way, transplant patients were also referred. So I've had some experience here and there working with transplant patients, but I've never been formally integrated into this clinic. I would say most of my work has been in electrophysiology, adult congenital, and I'm just starting to get more into heart failure and heart transplant. So just want to welcome you. And I'm actually hoping that I'll be starting to work with this population more. So this is non-scientific. I'm starting off with kind of an experiential slide that I put together with the help of the PFAC. And this is to maybe begin to start to think about different phases of transplant in terms of adjustment and psychological distress. The reason I chose this graphic is because I want to, right off the bat, say that any of these sorts of issues can come up at any time. So even though I've kind of listed them within the different phases, that doesn't mean that they can't occur at a different phase. And so what we're looking at here is in the initial phase, pre-transplant, there's a lot of variability in what people experience. Some people have a really rapid pre-transplant course where it's about survival and it happens almost before they can process it. And some people experience a much different course with very long, prolonged, slow decline and kind of a waiting game. And then there are some who experience both. There's a long waiting game and then there's a sudden rush at the end, or so it can be very different. The period after transplant within the first 1 to 2 years is really about rebuilding strength and adjusting to this new organ and all the medications and possibly complications involved. And in that phase, adjustment is really the focus. And I'll be showing you some data from a survey that also mentions a lot of doubt and worry during this phase, early post-transplant. In the period of time, maybe 2 or 3 years post-transplant to around 9 or 10 years, a phase of kind of relative freedom and vitality, kind of learning how to accept the new normal and learning how to get back to life and enjoy every moment of it. And then the period of time that's 10 plus years, kind of thinking about the data of 10 to 12 years, kind of average survival, beginning to be in a place where maybe there are some renewed existential concerns. And all along the way, I've heard from many transplant patients, there's this recurring theme of coping with setbacks. So if you thought that maybe after the next medical procedure or the next clinic visit, the problems would be resolved, it would be over, and you'd just go back to your life. It seems that that's not really how it works. It seems that it's really more of this kind of recurring, dealing with new obstacles, adjusting, and then kind of going on. So this is too much text. Please close your eyes if you get dizzy. But what I'm trying to do here is just summarize some interviews that I had with several of the PFAC members. Because when I was asked to give this talk, I was thinking about the transplant patients I've seen. And I said, the first thing I want to do is interview some of you to get a better sense of what your experience was and kind of integrate that with patients I've already seen. And the reason I'm going to share these 3 stories is because I want to highlight the absolute diversity of experiences with transplant. So being asked to talk about transplant, it's actually very hard to come up here and talk about themes or give some kind of overarching common experience when in fact, there's a lot about the experience that's very, very different for each individual. So first, I want to talk about a case of a patient who had no family history of any cardiac problems or medical problems. She had a 2-year-old and was 6 months pregnant. She was short of breath and presented to the ER where she was dismissed and told to relax. She went back to the ER within 24 hours and went into heart failure. For 2 days, she was semi-conscious and she lost the baby. She was helicopter transported to Stanford, put on ECMO, and listed for transplant in September. That same year was put on LVAD and had a continuous hospitalization until she was relisted in February and transplanted on March 2nd. During this time, her marriage was in trouble and she ended up becoming single through this process, returning home after her transplant as a single parent. And her parents retired to help with her care and her children's care, or her child's care at that time. She told me in this interview, my former life died with me on the operating table, but I've experienced amazing regrowth from what I thought was my ultimate downfall. And some happy news, this patient is now pregnant. She weathered a lot of complications, including partial rejection, osteonecrosis, and 2 hip replacements. She also found a new community, someone who had always been very social. She started leaning into disability programs. She decided she was not ashamed to utilize these. And she said to me, "You'll never be like your peers, but you can figure out who you are now." Just letting that sink in. I have to admit that preparing this talk was really emotional for me. I can't compare my experience to yours, but the stories that I've heard from these patients and from all patients are just astounding, not only in the challenges, but in the resilience. Case 2, transplanted in 2022, a marathon runner, super fit, suddenly had a stroke, lost all language. And during that time, right away from the stroke, it started rehearsing words to himself so that he would be able to get his language back. 2 months later, was found that he had a low EF and he got an ICD. Was stable for 9 years, was still running half marathons, but noticing a decline, gradual. Eventually, EF got down to 20%, started having VFib, started getting shocks, ventricular tachycardias, more limitations. an ablation, EF declining, but still very fit, not even being talked to about transplant with an EF of 15% because he was so fit. But eventually more VT, more shock, an ER visit, surgery, and placed on ECMO. This patient was listed and transplanted in the same day. Pretty unusual. Got straight back on the horse. He said he returned to working full time and he returned to running. And he said, I feel the sheer joy of being able to run again. My mental health is so much better when I can get out and run. So this patient had a recovery mentality from the start. From the first indication of trouble, which was the stroke, he was already trying to help himself recover. And after the heart transplant, he started walking more than a mile the first day home. In fact, he said when he went to clinic, they told him he was walking too much. So he had to back off. And he managed setbacks. There were medication changes, there were side effects. And he said, it's not clear sailing, but we manage. What was really key for me in that, in addition to the whole story, was that he said, we manage. And I got the sense that he has a team behind him, his spouse, his caregiver, his family. And this is so crucial in coping with transplant. Case 3, 2013. So this is a patient with a really different story, a very, very long 19 years of slow decline, a lot of waiting, a lot of thinking and worrying and wondering about what will happen. Will I survive? How will my family be? This was a slower process, listed, passed on the first offer. 1 year later was actually called in for transplant and put under anesthesia, but then woke to find out that it turned out the heart was no good. Ended up getting the transplant and then had to have post-transplant infusions. But once he recovered, as he was recovering, he said he was very driven to get back to the things that he loved, returned to working full-time, retired 5 years later, had some complications, and now is coping with more as kind of passing the 10-year mark, having some more complications and other complications of his original diagnosis. But I really like this quote. I can't sit still now. I never know when the music is going to stop, so I just keep going. For 19 years, I couldn't do much of anything. So some of the resiliency skills here, making meaning. This patient has jumped into advocacy, gotten therapy, been present, and focused on one thing at a time. And he said something that I've also found is true in the patient with the patients I work with, which is you have to be ready yourself to process emotionally your transplant. Also, really just bringing up this very ubiquitous issue of wrestling with mortality. So this average post-treatment expectancy and sometimes losing friends and colleagues from the transplant community and wanting more time. I'm sure all of these feel familiar. So I'm not going to be able to provide solutions or cover everything that I've just introduced, but I do want to suggest a few things that I've worked with patients with over the years for managing these different phases. So for pre-transplant strategies, one of the most simple things is to focus on what we know that is optimistic and positive. So if we hear about statistics on survival, we focus not on the statistic about failure, we focus more on the statistic about survival. And then we try to identify what are the specific fears. And sometimes people don't even really know what their fears are. So in therapy, a lot of times we really try to pin it down. Well, what do you think you're really worried about? And after sometimes cycles of conversations, we can get down to a specific fear, and then we can start to sort of challenge that and think about how realistic it is. Or if it is realistic, how could it be coped with? How could it be conquered? Then there's emotion-focused coping. So if there's a problem that you're worried about that you have no control over, which I think is very common here, it's more about soothing your stress response. It's about spending time with loved ones. It's about finding things that make you feel happy or fulfilled in that moment. Sometimes with preparation, it's just getting some practical considerations out of the way. So the legal documents, the insurance, the family discussions, planning caregiving, all of those things, if they're not getting done, they hang on your mind and make you feel more anxious. And then again, I'm probably going to keep coming back to this over and over, but identifying what matters most to you and figuring out how you can focus on that right now. And again, I feel silly saying this to you because you already know it. So I've talked with a lot of people about, could that have been better timing? Getting the call. The call just came in, guys. Are you ready? So it happens so fast. These are some things patients have said to me. It happened so fast. I was out of body. I was numb. I couldn't even process what was happening. Some feeling excited and hopeful, some feeling unprepared, scared, alone. And then this quotation from a website about transplant: "You may feel a surge of adrenaline, excitement, eagerness, a peaceful state of readiness, a sense of dread, shock, and disbelief. You may also feel sadness for the family who lost someone. At the same moment, you are thrilled to receive the gift of life. And all of these feelings are normal." Whew, that's a lot of feelings. So I wanted to just share a little bit that I found research about transplant. This is a very small sample size, but there's not a whole lot out there, I found. Within the first year, there's a lot of doubt and worry about recovery, about survival, and specifically one's performance. I know that there's a lot that people need to adhere to, a lot of guidelines in that first year of recovery. And I've worked with patients who are highly anxious about whether they're doing their part enough and correctly. So that's another place where anxiety and doubt can come in. Sometimes the caregiving relationships, there are struggles there. Sometimes feeling abandoned, and sometimes, I think all the time, doubting or worrying about the future. So that first year is really tough. You'll be pleased to see there's some data in another slide or two that's more hopeful. But some strategies for those first 1 to 2 years, that big adjustment phase, a lot of mindfulness. This graphic is about the rain, is really just about what is mindfulness. Distress tolerance, that's what my other box is about, some skills that can help distract from the distress, soothe, and improve the moment. And this is a really important one, but making space for loss. I found in my work with transplant patients that there isn't often a real explicit discussion about the loss before the transplant. Sometimes that slow decline, and then the loss of your own heart, and sort of the grieving that occurs before transplant. A lot of focus is on what happens after transplant, but making space for that loss and grieving what has been lost actually allows room for the future, for starting fresh in some ways. This is just a slide about social connection. I mentioned, having a team is so important. And this means that to have better outcomes, both emotionally and probably physically, to actively seek connection with caregivers, family, friends, other transplant survivors, providers, and community. Social connection can improve health in multiple ways, not only emotionally, but through biological processes and through behavioral processes. So that's such an important piece. And actually, it speaks to all of you that came here today, knowing that it's important to be part of a community like this, that this is also something that is good. So good choice. 3 years post, some of the themes that emerged when they asked the same patients in that small study: what have you been, how have you been doing these past 2 years? A lot more adaptation, a lot more acceptance, showing gratitude, feeling gratitude, trusting themselves and others. Excuse me. These are just some examples of different ways that people adapted during those years, adjusting their habits, following recommendations, adjusting their work situations, finding balance. And this quote is from an article: "Achieving acceptance and a solid sense of self-efficacy after heart transplantation is a time-consuming process that involves courage to face and accept the reality and adapt in every life dimension." And I've just written in the colorful text there some of the skills that are required to make this adaptation. So 3 to 9 years post, just some more strategies that can be helpful. I think probably the single most important strategy is flexibility. And I have this picture to the right about recovery from setbacks. That's actually a behavioral change model. I'm not sure it perfectly captures what I'm going for here, but the idea being that there are so many setbacks, and being able to adjust, to be flexible, to have an open mind. So that last slide about psychological flexibility. Psychological inflexibility is kind of basically having rigid beliefs and being highly invested in control. And psychological flexibility, especially when control isn't possible. Psychological flexibility is more being open, being willing to shift beliefs, being willing to look at what's happening in the moment and make new conclusions, and to let go of control when needed. Post-traumatic growth is a wonderful thing about trauma. You can go through trauma, but it's not always bad. In fact, there's usually a silver lining. And post-traumatic growth is really common. This is a survey of 59 youth, 21 young adults, and 95 caregivers after a solid organ transplant. High rates of post-traumatic growth among all of these groups. Appreciation of life was the highest post-traumatic growth subscale. So really, really savoring and appreciating every moment. Certain types of coping were associated with greater post-traumatic growth, like religious coping. And caregivers of children who had an acute medical condition endorsed greater post-traumatic growth than caregivers of children who had a chronic illness. So that kind of discrete period and being able to recover from that, as opposed to it being ongoing and ongoing. So 10 years post strategies, as always, meaning-focused activities. But I think recognizing resilience, I think that's one thing, if you walk away with anything from today, is that I want you to really think hard about your resilience, whether you're a transplant recipient, whether you're a caregiver, you have had to weather a lot of change, and you need to give yourself credit for that resilience, even if you've struggled and even if things have been really hard. You're here, you've gotten through it. So give yourself credit for that. Religious and spiritual practices, gratitude practices, present moment orientation, and values-based living. And there's a type of therapy that I offer called acceptance and commitment therapy that's great for this. So just 2 more slides. I wanted to show this slide about quality of life at 15 to 19 years post heart or lung transplant, that there's some decline over time in physical health related quality of life, but actually no change in mental health related quality of life. And mental health related quality of life for transplant recipients is better than the age-matched population norm. So more psychologically healthy as time goes on than the average person in the population. So that's actually some post-traumatic growth there. I think that's something to be happy about. This is my last slide because I didn't want to start with distress, but I do want to acknowledge that depression, anxiety, adjustment disorder, and PTSD are higher in transplant patients than in the general community. So the community rates are on the far right. Transplant rates are significantly higher. And I think that speaks to the reason for having more involvement from cardiac behavioral medicine, which is psychologists like myself or social workers. But there's a role for this kind of help. And I know that the PFAC is really strongly invested in getting more of these services available at Stanford, both in the advanced heart failure clinics and in the transplant clinic. And I'm pleased that I have a colleague at Northwestern who is a cardiac psychologist. There aren't that many of us, but her focus is heart transplant, advanced heart failure and heart transplant. And she wrote an article, which I pulled from for this slide. And I'm looking forward to consulting with her and seeing how I can help this population more in the future. Thank you.
All right, so I think we'll go ahead and get started. We have a couple of presentations for the evening. We're going to kind of recognize some of the people here and recognize some of you as well. It's been 5 years since we've done this in person, and maybe you thought I'd have like some big, incredible presentation. I don't have a big, incredible presentation for you, but I wanted to kind of bring your attention to something because everybody's here and I'd love to get your feedback. So with a website. So the hospital has a number of websites that are devoted to heart failure, some of which I didn't even know existed, but they're there and they're okay. I'm not going to totally trash the hospital's websites, but they're all the same, right? So the couple downsides to the hospital built websites are they all have to kind of have the same format. They're pretty slow to make any changes to them. So it's hard to keep updating them in any way that's timely. And then they all have these sort of like rock star pictures of like doctors and patients that don't even look like they're sick. And you're like, these aren't people that I've ever seen. These aren't doctors that I've ever seen. Who are these people? And so I decided to kind of put together our own website, sort of our on the sly at first, but now it's kind of out there in public. And it's not taking the place of the hospital website because there's still important information there and it will direct you there for certain things. But I was hoping to sort of make it a little bit more personal and to have pictures of our team. So you could look at our doctors, you could look at our fellows, you could look at some of our staff as well. So it looked like the people that you see when you're in the clinic or you're in the hospital. And then it covered both heart failure, so before transplant, and then after transplant and after mechanical circulatory support as well. And I think it was okay. It allowed us to do some things and post some information that we weren't able to post to sort of a central space before and in a way and in a timeliness that we haven't been able to really achieve before. But there were some downsides, and some of the downsides were I was trying to serve kind of many different audiences. I was trying to kind of serve you guys, your caregivers, our colleagues around the country, potential physicians who are interested in coming here for fellowship, our sort of research collaborators, and some of our colleagues around the country. So it's a big audience. And so after it had been up for a while, the PFAC kind of gently said, hey, can we talk to you about the website? And I said, sure, I'd be happy to talk about the website. And they had some very gentle suggestions that maybe it wasn't organized in a way that was totally perfect, which is totally fine because you're looking at the webmaster here. And my being webmaster was like a 6-hour online course that Stanford made me take before I could change anything on their websites to make sure I didn't like totally crash the whole technology of the university. And I'm also glad our previous speaker is no longer here to hear me talk about this sort of very basic technology. It's almost embarrassing to hear him talk about AI and for me to talk about my silly little website. But the feedback that I got was super helpful and they're continuing to help me. So amongst the PFAC, amongst all the talents you guys have, is there's a bunch of people who know web design or have worked on web design, and they kind of gave me some very helpful hints. And so I went back to the people that helped me put this together. It's only flexible to a certain point. I can't do a lot of crazy stuff. There's only certain things Stanford will let you do and certain ways they'll let you present stuff. But within that sort of context, they're going to help divide the website into sort of a more patient-facing page, a more patient and caregiver-facing page, and then the more sort of medically-facing page. You know, so I said, you know, we like that picture when you open up the web page. I just changed this yesterday of like an open chest and someone and Will Hiesinger doing a heart transplant. But some people are like, that's a little bit much. Like, I just want to come and see like what my COVID recommendations are. That made me throw up. So I get it. I hear you. We try to just kind of put any cool pictures we have. It kind of didn't occur to me that maybe that's not the coolest picture to have on your opening web page. But anyhow, so it's changed. So a couple of things. So one, the new version isn't out yet, so it's coming. And the reason it's not here now is because of me and my time to be able to do it. Again, I'm the webmaster, which is frightening to think about. My kids are like, they see me doing stuff at home and they're like, oh my God, I can't believe you're like editing web pages, Dad, what are you doing? So it's coming, but I think the thing I wanted from you guys was a couple of things. One is you guys have so many awesome stories and so many cool things that you've done and so many sort of life things that you've checked off that you send to our coordinators. And I would love to be able to post that stuff on the website, because particularly for the patient-facing website, because I think being able to see those sorts of stories for patients who are thinking about transplant or going under transplant evaluation is super duper important. So this is actually the live website, and I'm going to click on the thing and hopefully it works. I'm like a little bit nervous to do a live thing, but when you click on the heart transplant, oh, look, there it is. And there's Will carving up somebody's chest. So maybe I can take that. But so these are examples of sort of what we put in. So just patient stories, cool pictures, memorable life events, brief little descriptions. You know, you don't need to write a novella, just something that kind of tells you what it is. And I think this really hits home for our patients who are looking at transplant, just some really cool stuff. I mean, it's great coming here once a year or every other year and everybody sees it in person, but this is not visible to the outside world for the most part. So more of this stuff, I would love to see it. So either send it through the PFAC or send it through your coordinators, and with a note that says, I'm okay with you putting it on the website, that sort of indemnifies me of any sort of legal things and makes Stanford happy too. So that's number one. More stories, would love to see it, would love to feature these sorts of things. I'm sure we have more stories than we have web space for, but we can sort of space them out. We can tweet them out and do that kind of stuff with them as well. The second thing is, one of the other things is sort of frequently asked questions. There's not a great place to get it, and some things are changing, like COVID recommendations, or I don't know, the way we think about treating certain things that we can kind of put out there as FAQs. So you can go back and refresh yourself, and we can steer people to, if there's something new coming out, if there's a programmatic announcement that we can put on the website, we'll put it on the website. Obviously, we can send it out through email and other methods too. But I would love to hear from you guys, like what would be useful information to have on the website is like quick FAQs, like COVID recommendations or something like that. We can put that kind of stuff on there, and we can, we can update them and then archive the old questions so you don't lose the old questions. But I would love to hear from that. And then just sort of in general, what else you guys would like to sort of see on the website or might be useful to have on the website. We will announce when the sort of version 2.0 kind of goes out there, so you can take a look at it and navigate it through. I think one of the other feedbacks I got from the web crew that was advising me was that it was kind of difficult to navigate. Some of that's just sort of the Stanford thing, but some of it's things that I think we can fix as well. So there's my kind of bare bones technology, but please let me know what you think of the website. We would love to see your pictures and stories, send them our way, and we'll get them up on the website and hopefully can share them with everybody in the wider audience. So with that, I'd like to introduce Michael, who was also one of the people on the PFAC that was helpfully telling me that maybe I wasn't quite hitting it quite right with the website. But Michael's was transplanted back in 2013. I think you all know him from the PFAC. He's been a member of the PFAC for a long time. He's now chair of the PFAC. He's been active in the peer-to-peer program as well as active with Donor Network West. In the past couple of years, he's seen his, I think, twin daughters. He's walked them down the aisle. He's seen his son graduate with a master's in accounting and sort of is celebrating life and riding his mountain bike, sometimes recklessly, around. And I think is probably most known in our little community in the hospital for having a dog that's named after one of our post-transplant coordinators, Gabby. So, and that's a good thing. It's a nice thing. So with that, I'll introduce Michael to talk to you a little bit about what the PFAC is doing.
All right here.
Okay, let me get out. Oops.
Let me get to the slides here. That's me. There we go. Okay, welcome everybody. It is so nice to see everyone once again. As you're probably aware, this reunion is being put on by the Stanford Heart Transplant Patient, Family, and Advisory Council, or PFAC for short. Unfortunately, due to COVID, for the last 4 years, we've had to do this reunion in a virtual format. But our goal was to somehow to bring this back to an in-person event. And tonight, folks, we made it happen. And we did this through the incredible work of the members of our PFAC, who I would like to acknowledge right now. Please stand as I call your name. Susan, Carolina, Eric, Subbu, Sri Lanka, where are they? Linda and Steve. Elise and Jordan. And Janine. Hopefully I counted everyone right. I'd also want to give a huge shout out to our faculty advisors, Nicole, Gabby, and our lead faculty advisor, Helen Lucart, who pretty much does it all. So thank you, all of you, for that. Every year, our PFAC comes up with a theme, and we try to carry this theme throughout the year in our articles and in our guest speakers. Last year, our theme was overcoming obstacles, and this year, our theme is resilience. Now, according to the dictionary, resilience means the ability to withstand or to overcome quickly difficulties. In other words, toughness. Now, I've had the great honor and pleasure of meeting and speaking to many heart transplant recipients. And I can say without a doubt, you are all very tough. In fact, I don't think you can go through a heart transplant journey without being resilient. As we all know, our journey is filled with many emotional highs and emotional lows. The highs are awesome. You're looking good, you're feeling good, and then one day something happens and you suffer a setback. Now, I don't know about you, but in my journey, I've had many emotional highs, such as the ability to go back to skiing, the ability to go hiking again, and to be able to walk my daughters down the aisle. But I've also done some crazy stuff with my kids, like bungee jumping. Not sure if I'm going to do that one again. But unfortunately, I've also had my fair share of emotional lows, with the worst one coming just this last summer. Even though I had many different eye surgeries, I eventually lost the eyesight in my left eye. But unfortunately, I started to lose the eyesight in my right eye. I don't know about you, but when I suffer these lows, I can get a little upset, maybe even a little angry. And I find myself looking up at the sky and saying, "Really, God? Really? You took away my heart? Now you're taking away my eyesight?" But eventually, I start to calm down and my resilience kicks in. And I tell myself, "Michael, you got this." And with the help from our amazing doctors, nurses, and the whole rest of the gang here at Stanford, they help me to get back on track. Because that's what we do as heart transplant recipients. We get back on track. We may bend, but we don't break. And that is why I look at all of you and I'm filled with so much joy and warmth. We are an incredible community that has overcome so much. So before I end tonight, I want you to just take a moment and look around this full room here and look at your fellow brothers and sisters. And let's all give everybody here, along with our family and our amazing caregivers, a huge round of applause. And always remember, what does not kill us will make us stronger and more resilient. So thank you all.
So like the website, sometimes transplant can be the patient perspective and the physician perspective. Our next speaker kind of can live on both sides of that fence. So John was transplanted in 1999, and he's currently one of our cardiothoracic surgery residents. And so he got his MD from Harvard with a combined program from MIT. Lots of very smart people here with us this evening. And he trained as a biomedical engineer as well. His long-term goal is to become a congenital cardiovascular surgeon and impact the world of not only congenital surgery, but transplant and mechanical circulatory support. In his spare time, he says he likes hanging out with his roommates, and he's going to be married here in the not too distant future. Or has that already happened? so soon to be married. So John is going to give us a talk called "The Story of a Heart," giving his sort of perspective on being on both sides of the patient and physician fence. John, thanks so much for being here.
I feel a lot shorter standing next to Dr. Tuderberg. Well, I guess I'll spoil the kind of end. This weekend, Victoria and I got engaged, so it's kind of a big fun thing. So, yay. I figured I'd tell a little bit of my own story here, but I tell you, this is the first talk that I've been nervous for in a long time because I haven't really told my story to a bunch of transplant recipients. I feel like when we tell these stories to people who haven't had transplants, the story hits a different way. And with all of you guys can relate. And also, I means I have to tell it really well. So I had my transplant in 1999 and I was 4 years old. When I was 3.5, I had the flu-like illness that didn't really go away. It was 2 weeks in, we had been to the doctor a couple times, and my mom, with that extra sixth sense, was like, we need to do something, get some kind of imaging. In kids, we don't x-ray them as quickly or all these different things because they just are resilient and radiation and whatnot. So we got an x-ray and my heart was enlarged, and they're like, we should get an echocardiogram. We'll do it next week. My mom said, no, we're going to do it tomorrow. And we did, and it was good because my ejection fraction was 4%. Kids are somehow magical, it can not be dead with that low of an ejection fraction, but that's just how that all works. So I went straight into the ICU, and at that time we didn't have those Mironone backpacks that they have nowadays. So I was on dobutamine in the hospital for the next 4 months. It was a small, like 15-bed ICU in Salt Lake City. So we got to know everybody. I had a lot of fun in the hospital. It's why I still work in a hospital. I saw Santa in the hospital. It's why I believe in him to this day. I made a favorite nurse friend that I proposed to when I was just after transplant. Sorry, Victoria. She told me that, Nurse Rose told me that at one of my post-op appointments, I came up to her and said, when I turn 5, we're getting married. There are engagement photos of that time. I also was given a squirt gun and said, go shoot all the phlebotomists whom I called poker people, because of course I hated them. And they pretended to die, and I thought that was great. Maybe a little bit of a red flag, but obviously I loved the hospital, whereas my parents hated it. So around my birthday, February 2nd, I again had a grand old time. There's racing suit, tricycle pictures of me riding through the ICU, but I was still very sick. I got to recently meet the PICU fellow who was taking care of me the night that I crumped, because he was a fellow, and he's now the director there. And he said, I was so scared that I was going to mess up the kid everyone loved, but he was tasked with putting an art line in me because I was not doing great. And I crumped. My blood pressure tanked, and it was a whole issue. And the attending cardiologist, Dr. Shaddy, who Dr. Bernstein, who he's still floating around, trained with, there we go. I was like, he told Dr. Woods, you go take care of another patient. I'm going to take care of John now. They put me on a balloon pump that night, and it didn't look great. My kidneys were done. My creatinine was 8. It was an absolute mess. The whole thing was a mess. Unfortunately, for another family in that same ICU, their kid had been hit by a car earlier that day, or maybe a day before that. And he was declared brain dead that day, and his family was wrestling with organ donation. They decided to donate their kids' organs with a little of help of pre-HIPAA things, like the mom walking around the ICU and asking someone what I was waiting for or what was wrong with me, and someone told them waiting on a heart. And I received Christopher's heart February 11th, 1999. We met them in 2020, just before COVID. There's a whole video, but that's not the point of this talk. But the road post-transplant was not easy for any family, whether you're 4, 50, 20, or anything. But for me as a kid, one of the things that I think most of you guys will have a better understanding than me of is this idea of the pre-transplant life. For me, pre-transplant life doesn't really exist. I was too little, I don't remember. So my idea of my life growing up was that I was a transplant recipient and I'm so much cooler than everybody else. That comes with its drawbacks, but a lot of times, chronic health kids get bullied in school. In kindergarten, I did bully someone once for not having a transplant. Bit of an overshoot from where you're trying to go, but whatever, it's pretty good, honestly. I had complications like any transplant recipient does, from being sick more often to having some sinus surgeries. I just had another one this last summer. It's my 5th, but whatever, it's fine. But to some bigger complications where when I was 9, I just was stagnant in growth, got 105 temp, had a little bit of night sweats. For those, any residents in the room, those would be symptoms. It was not good. It took a while for them to diagnose that I had lymphoma and PTLD because it can be many, many things. But again, there was a story of my mom pulling me out of one hospital because they were going to do the equivalent of Carious testing that we did in Boston, where it's a send out fungal test. It's going to take 3 weeks. And she's like, 3 weeks? What are we going to do for 3 weeks? Anyways, she did her research and we ended up at, we love DC Children's, but at the time, it was time to move to Pittsburgh Children's, where Dr. Weber was. He was the expert in PTLD there. And long story short, we moved around for different things. And then after that, that year after that, I had a severe bout of rejection where, ATG wasn't working. I got serum sickness. I thought it was so cool that I got to have horse serum and rabbit serum inside me. And then I got serum sickness, and that wasn't fun, but that was fine. I got morphine, and my little 10-year-old self thought morphine was great. I actually think it's probably a big red flag to anesthesiologists when I would come to biopsies and say, I want this much Versed and this much fentanyl. At the time, I didn't really realize how weird that might sound, but now I'm like, oh, wow. That must have been a little concerning to everybody, including my parents. And they once tried to give me laughing gas, and I told them, I do not want that. I want fentanyl. But anyway, after the rejection, it was interesting. I met Dr. Starzl during that time in Pittsburgh, which, for those who know, like the father of liver transplantation and of Prograf becoming a mainstay drug. And he was funny, he's like, an emeritus professor, retired. He got like his 4 golden retrievers in his super messy office. And he tells my dad, you should get him on tacrolimus, Prograf, get him off cyclo. Anyways, that worked for me. And then I was fine with rejection. And I basically have been on Tacro and Rapamune ever since. I share all the bumps because I think we all relate to having different things not go our way. And I think people take a look at me and they're like, oh, you look normal. And if my family or Victoria is around, they can say he's definitely not normal. But even from like the health perspective, I'm not. I take that as a badge of pride, which probably is evident from my bullying story that from my younger years. I think that the stories that we have can be challenging, but they also allow us to do something with our lives that I think people that don't experience transplant either as provide or something like that in their lives with their family members don't always get to see. And that is sort of the element of understanding that our minutes are numbered, so to speak. Every moment of life now for me is very acutely a second chance at life, as we all sort of experience. And I think there's a challenge to not letting that become a pressure on you, but more of a freedom of, oh, I can kind of do whatever I need to or want to now and not feel like this pressure. My family was lucky enough to be able to shape that for me, to have that idea of do whatever you want to give back, but not putting pressure on me. It probably helped that when I said I wanted to be a doctor when I was 4 and was doing fake surgeries on my brother, that they didn't know if I was going to live long enough to do that. But each step of the way, going to 2nd grade, I remember my dad cries a lot, but he was crying. He's like so excited that I made it this far. And I was 7 and just like, okay, Dad, I'm going to leave you now and go to class. You're making the scene. Every step of the way, I think, has been a monumental moment for them. And one for me that has just become routine in a sense, which that's the joy of having a successful transplant. These things become routine. But even in the most annoying moments for me, which luckily most annoying means having to go back to the ENT doctor several times because I'm not the normal patient. Go figure. I come back to one, this isn't that bad. Trust me, we all know like, oh, what things are actually difficult. But the second just being, well, alternatively, I could just not be here. So it's fine by me. I think things that were useful in my path that kind of apply mostly to those who are adolescents in their transplant, that transition of learning how to take care of your health yourself. For me as a child, of course, I initially didn't know how to swallow pills because I was 4, but my parents taught me at 6 years old how to swallow pills and to fill my pill box by the time I was in middle school. Really early, but I was also gullible enough to believe those things were fun. So that's how they did it, you know? So there's some pros, I think, to having a transplant in the sort of gullible stage of childhood. But it's, I think, not dissimilar to the reality of when we are adults and have to take ownership of our health and find ways to integrate that. That's not just frustrating and debilitating. And I think that having supportive people around you that love you and accept that this is a part of life, but isn't a burden, I think is a big thing that's been really important and helpful for me along my entire life journey with this. I think the last thing that I'll sort of talk about is just how important, obviously, the donor families are to all of our stories. I was lucky enough to meet my donor family in 2020, thankfully, just before COVID, or would have like never happened. How we found them was kind of ironic because my parents had saved a newspaper article that had had the last name of some 8-year-old boy in the newspaper who was hit by a car around the same time that I was transplanted, which is totally not HIPAA compliant. But it worked out great for us because my parents just had this sixth sense that this was the donor family. And when one of my parents, one of my dad's employees, or not employees, but coworkers, was doing stories on the different employees at the company to try to help boost morale and make it, you know, more intimate kind of community. They, of course, did a story with us because they had been with us since I had cancer. And they asked, do you want us to try to find this family? I naively said, oh, I've already tried to find them. You can't find them. They're a reporter. I don't know what I was thinking. They found him within 12 hours. I need some humility sometimes. Just ask Victoria. Of course, very sensitive discussion underwent before it was, you know, figured out that they did want to meet, and we, of course, wanted to meet. And I think the moment of getting to let Christopher's mom, Christopher's my donor, and his sister listen to his heart with a stethoscope is probably the most like supernatural, like tangible feeling that I'll probably ever have. It felt super normal and also super weird. Nothing like fantastical, but just this bizarre reality of seeing them listen to their son's heart and how normal it is for me. This is something I take to when I'm working in the hospital, which for those of you who know what residency is like is most of the time, and try and think whenever I get to work with patients outside the operating room about their families and how they're experiencing this. That kind of is easier for, I think, me, who's been in all different kinds of units. But I think that it is super important. It's something I always think about because it's hard being the patient as much as it's also sometimes hard being on the scrub side, seeing such sad stories. So it's awesome for people like us to be able to share these stories, because a lot of the folks that are caregivers only see the sad stories and it can be depressing. So feel free to share all these things, and wherever you're at in your transplant journey, whether you're 1 year out, months out, few years out, decades out, it does get better. I do eat raw cookie dough, though I can't recommend it. Sorry. And I should just end with that because I'm going to be in trouble soon. All right, guys.
I'm not advocating for raw cookie dough. I'm not advocating against raw cookie dough. But so our next speaker is Mr. Wilson. And I was kind of looking up sort of how long ago did I meet him? And I was looking back through Epic, which is a sort of electronic medical record, which is sort of mostly a curse, sometimes is a blessing. But it was almost exactly 4 years ago. It was on October 29th, 2020, when I met him for the first time. He was referred from UC Davis. And he was sicker, and we thought, boy, you know, he needed a transplant. Then there was some administrative stuff about kind of getting him an evaluation. But by the spring of the next year, we'd had him fully evaluated. And I sort of looked up the dates because I was like, geez, I don't even remember him being in the hospital because it was so fast. So we listed him on April 13th. We transplanted him on April 18th. And on April 30th, he was out of the hospital. So he had a very light touch on our system. And since we were chatting a little bit outside, and I think he's only ever been admitted back to the hospital for gout, although some of his gouty flares were pretty bad. And he's been sort of off to the races ever since. And, you know, he's one of these people that is was just always exceedingly positive. And even like right after transplant, we were just talking about this. He was like up and standing next to the bed in the ICU and like wanting to like jog in place. And everyone's like, whoa, hold your horses. But he's been sort of nothing but positive throughout this whole thing. And he has a fantastic story that I'm looking forward to hearing. He has this great connection to the NBA. He's worked with the NBA for almost 30 years with the Bucks and the Mavs, as well as the Sacramento Kings. And he was nice enough to get a jersey, and he signed it, and it's actually hanging outside my office now. So every day when I come into my office, I'm reminded of him and his story and his hugely positive attitude. So I'd like to introduce him to come up and talk about his introduction to his new heart. Dwayne? Oh, there he is.
All right. Hi, my name's Dwayne Wilson. This one. And yeah, I was transplanted in April 21st, or yeah, April 21st of 2021. And like Doc said, I think it was, and I call him Doc. I'm an MBA guy. So we just use like little acronyms like that. But yeah, I was transplanted in 2021 April, and like he said, it was for me, it was just an unbelievable moment. I think he was right. I was up in that ICU, and I remember the nurse was in there. I can't remember his name, and he was kind of standing there, and he was like, they hadn't come through with the rounds yet, and I was asking him about something to eat, and he just kind of looked at me and he says, "Do you want something to eat?" And I said, "Yeah, I'm hungry." And he was like, "Well, what do you want?" And I go, "Do you have a menu?" And he says, "Well," he goes, "to be honest with you, we don't have menus in here. So no one's ever eaten in here after transplant." And I said, "Well, that's why I'm here. We're changing that, you know." So yeah, so he went on, and I think at the nurse's station they had some applesauce and they had some the crackers, and I said, "Yeah, let's try that." So he brought a couple of those in, and I ate them. And I said, "Can I still get a breakfast?" And so I think he ended up calling the doctors or talked to somebody to see if it was okay for someone to eat, you know. And I was kind of thinking to myself, I was like, "Oh, I mean, they got to feed you. I mean, I know I got a new heart here, but I got to eat too." So anyway, I was allowed to get some food. So I said, "Well, let's just get something easy, some scrambled eggs and oatmeal. We'll try that out." So they brought in a bowl of oatmeal, they brought in the scrambled eggs, and I ate them. And then I asked him if I could get another order. And so then the funny thing was, I guess for me, I was like standing there, and at that point, I kind of tricked him, I think, because he came in and I said, "Can I sit on the edge of the bed or just kind of get up?" And he was like, "Well, okay." So they kind of, you know, and you've all been you know what it's like when you're transplanted. You got wires and the one thing with the surgeons, I don't know if the surgeons are here, Dr. Boyd, but they don't really get the wires and all that kind of stuff in a nice little, you know, line. Okay, so they just put stuff. I don't know what. And when I think about it, looking down at everything, I'm like, there's wires all over the place. And so they were like twisting the machines around and sliding stuff around, sliding me around, you know, just trying to get all this stuff situated so I could just sit on the edge of the bed. And finally they did it. And there was a couple of the nurses were in there doing this. We got that all situated. And then he literally asked me, you know, just kind of sit there and, you know, just kind of raise your feet up and, you know, bring your knees up. And I was like, okay. And my work in the NBA, I was a strength and conditioning coach for 27 years for those 3 teams. So a lot of times, you know, going through some of those types of exercises, those types of movements, they were pretty, to me, they seemed very simple. And I said, "Look, I want to stand in March." And so I did. And he at that point, the doctors came through and they were standing there at the doorway. And I was just standing there marching. And I remember Dr. Trudeberg was kind of in the background. And my transplant was during COVID. So I was in there, and there was, you know, your best friends were the nurses and the doctors. And I had one sister was able to come in. So there wasn't a lot of visitation or anything like that. So so I was standing there, and I could kind of see on Dr. Tuderberg's face. He had the mask on, but you could see this big smile on his face, like, yeah, I kind of thought this guy was going to come in and change our protocols for the rest of our duration here. So I thank you for that. But in truth, I think for me, one of the biggest moments for me, or not one of them, the biggest moment for me, I was diagnosed when I was 17. So I was played a lot of sports. If there was a ball, I played tennis, I played football, I played basketball, I played track, and I did it all. And for me, and I think going forward, coming out of high school, I was thinking, took my trip to these different schools for potential scholarships and all this kind of thing, and was really looking forward to that, going to school, playing a sport. And at that time, I was looking at, well, going to college, I was looking at basketball, football, or track. I couldn't really decide what, but just depending on what the school I wanted to go to, which at the time, and this is kind of tough for Stanford to say, University of Washington was kind of where I wanted to go. I grew up there in Washington. And so anyway, while I was there, at that point, during some practices, I ended up having, some not necessarily, I didn't pass out, but I was having some lightheadedness and this kind of thing. So that's where I ended up leaving in high school, going up to Seattle, and that's where I was diagnosed with hypertrophic cardiomyopathy. So seeing some of those slides earlier today, I was kind of like, thinking about, well, where was AI back in 1979 when I could, but anyway, so basically at that point, it kind of shut down anything, or I should say my aspirations to play sports. But not only that, it was like just a lot of life's simple things, running, riding my bike, or doing a lot of things. I always had limitations. And I think for me, the other thing I did, I would wake up I was diagnosed at 17. I didn't get transplanted till I was 58, so for 40 years, I literally dealt with, what you all understand, the arrhythmias, the lightheadedness. And I think for a lot of times, especially, when I'm working in the NBA, and in that sense, you're working with, those 1%ers in our society. These guys are just ridiculous at, they just roll out of the bed and everything's easy. And I'm in a weight room, and I've got to train these guys. I've got to get these guys to do what I need them to do. And for me, each day it was, and then deal with all the other issues that I was currently, going through. It was difficult, so there was a lot of different things that I was dealing with there. But one of the things I always had to deal with, I'd wake up in the morning, I'd sit on that edge of the bed, and I would kind of think to myself, okay, what's bothering me right now? Is what's going on with the heart? What's going on with, this? And all your organs are just wreaking havoc, with anything that you want to do for that particular day. And I really got in tune with my heart. I really got in tune with what it was doing and what was going on. I found ways to stay active, to do things without, technically killing myself, that kind of thing. So I just kept working at that. And I think for me, all those years, and sometimes when I think about it, I think the hardest part for me was actually getting to the point of a transplant. And I think for me, after the transplant, it was the feeling. I remember the day they came in, and I had a pacemaker. They pulled that out, which I'm so thankful for. Some of the wires are still there. I still kind of throwing here. I'm always like, yep, there's the wire there. So those are pretty much embedded in me for life. But when they came in the day to turn that external pacemaker down, which I didn't know at the time that I had a pacemaker. You didn't explain that to me, Dr. Chris. Yeah, you guys didn't let me know what was going on with that. But the funny thing is, they came in and they said, yeah, we're going to turn this pacemaker down, and you're going to feel your heart. And I was like, okay. So, and at that point, I think it was Dr. Cush explained that, yeah, your heart is, right now we're letting it get used to your body, and letting, everything settle in. And then we're going to turn this pacemaker off. But right now the pacemaker has been running everything for the last, for these last couple of days. So I was like, okay, so we're sitting there, and when they came in, and this, I think this is a Stanford thing. They don't come, it's not one doctor that comes in, they come in 9 deep. So, and I think you guys all understand that. So it's like, Dr. Tuderberg, Dr. Cush, I think Dr. Wheeler was there. And this time we weren't talking sports. So Dr. Wheeler was there, Dr. Lewis was there. I think Dr. Mamich was there. And if I've forgotten anybody's name, I'm sorry, but there was a lot of them that came in. And initially I thought I did something wrong, and which could happen. They had the bed alarm was off. I did make a deal with the nurses and the doctors, so they turned that bed alarm off so I could actually get up and move around. I proved to them that I wasn't going to fall or wasn't doing anything too crazy. But there were times when I was alone, and I'm not going to tell you about some of the things I was doing. But anyway, so they came in and they started to turn this down and say, yeah, so you're going to feel your heart kick in, or your new heart kick in. And so I was like, okay, so I'm ready. So I remember they came in and they just turned it down and basically turned it off. And during that time, or before that, I think when I was talking to, some of my friends that would call, and we would talk about this, and everybody's always wondering what, for what I was going to do after I get this heart. Some people are saying, you're going to go back and you're going to get back in every sport you can. And in my own mind, I kept thinking to myself, I was like, no, truthfully, really want to do is I just want to go camp. I want to go find the best views in any state. And I just want to sit there and just sit and look at that with my dog. And that's all I want to do. So I wasn't looking to do anything. I didn't want to run, didn't want to ride my bike. I don't want to do any of that. I just want to enjoy this new heart. And I remember when they turned that down, and for me, all those years of just, feeling a bad heart, you're having arrhythmias. And some days it felt like I was running 100 meters the whole day. Just that type of tired, where you're not just on the track dead tired, but you're just worn out, and just so many different things going on. But I was very in tune with that heart, and getting the new one when it kicked in, I kind of looked behind me. I thought somebody had kicked the bed. I literally felt like it, and I'm looking down at looking at my hands. I was just like I could see the vein. I could just see everything was just like moving. And the beat was so strong. And I was just like, you've got to be kidding me, and for me, after all those years and then finally feeling what, a normal heart felt like was just truly amazing. And I think, with that, and to this day, I guess what Stanford has given me is at night, the last thing I feel is that heart. So yeah, so for me, it's all those years of just feeling the limitations and finding ways to get through it. I think listening to everybody talk here today, it's a lot of the talking about the adversity, or talking about the tough situations, or talking about all those different things that are just so that you go through to get to this point. And I think for me, it's those are the things I'm trying to forget, and more or less trying to just keep moving forward. And I think it's one of those things. You never can forget that, but it's something that where I'm just so glad it's behind me. And I think for now, it's one of those things where, we all talk about that. It's like every day, every hour, it's just, you're just living in that moment. And I think, going through that process, I think when it all started, I was like, through my work, I met a lot of people, just a ton of people that I would never have met, any other walk of life, I don't think. And I think for me, it was one of those things where you're going through all of this, and I didn't know anybody who had a heart transplant. So I'm trying to, when I was coming up to do this, I was like, I got to talk to somebody that's done this. And I didn't know anybody, couldn't find anybody that had a heart transplant. And so I think during that time, I said, well, when we get through this, that's going to be my goal. I'm going to go out there and introduce myself as a heart transplant recipient, and let people know what it's like. And I think it's great to be in a room here today where there's so many other people. My twins are here, is I guess is what I can say. It's like, you guys are my brothers and sisters, and it's just amazing, the life that we have to look forward to, with this special gift that we've been given. And I think I sit there and I try to think of all the different ways to show my appreciation or to show my gratitude or express my gratitude. And I think, two simple words are thank you. And I think they're simple words, but they mean a lot. And it's what Stanford and what all these people, the nurses, the doctors, my caregivers, what I put them through, for those families. I sometimes I talk to other transplants, and I think initially when I see their caregivers, I'm like, yeah, make sure you have plenty of them, because you're going to put them through a lot of mess, so it's tough. And I think the caregivers and everybody involved in this, you can't do this alone as a recipient. And to me, I think I'm just so happy to have that the family, the friends, and those doctors, those nurses, to get me through this, because it's as tough as you all think you are, you think someone might be, you're only as tough as those people that are behind you, and those people that they're the ones that push me along daily, and even to this day. So to me, being able to come back here and talk to everybody here at Stanford, and I see a lot of the faces that were there when I came in, and not that I'm all big and muscular now, but it's like I was like a really little skinny thing when I came in here, and you talk about that attitude. I was trying to be as kind and just be as not necessarily kind, but just trying to be myself, so to speak. But I think just knowing what I had to look forward to, I was like so excited to get to that point. And even with all the roadblocks, the hurdles, and everything else that you have to go through and continue to go through, sometimes I don't mind those hurdles. It gives me something even more to work at. And I think nothing is given to you. Nothing is going to be perfect. And I think sometimes those hurdles are just put there because you have to find it within yourself to find ways to get through it. And I always tell people, it's like, I wasn't, when I went through all of this, it wasn't something where when I looked at those hurdles, it wasn't something that I ran the hurdles. So I didn't want to jump over them. I wasn't trying to go around them. Didn't want to go under them. It's like when I got through that hurdle, I'm going to smash. I'm not going to cuss in here, but I'm going to smash that hurdle. That was my, when I hit that, I'm blowing it up. I do ever want to see that again. And like you said, when I came in, and the one thing that brought me back was gout. And I was kind of like, and I knew a lot about the heart. I didn't know what gout was, but I'm telling you right now, I will do the heart transplant in a heartbeat before I got to go through gout like that again. And I think right now that's probably my biggest, thing that scares me the most. I can't even think of the word. That's the thing that scares me the most in my life is gout. Okay, so I mean it's brutal, and I appreciate you all, what you did to get me through for the heart, and I appreciate you even more to getting me through that bout of gout that we had to deal with. But again, I truthfully just want to thank you all. I mean, I could talk up here forever, but we all got to go. But in truth, I just really wanted to give this time to thank you all and thank Stanford for what you've given me, given my family, and given my friends. And the last thing I want to talk about is my donor and that donor family. I haven't been able to meet them yet, and but even with that, I still every day I think I know who that person was because they're in me. And I'm not going to get through any of this without them. And I think having this heart and even hearing from Dr. Boyd, when he it just seems like everything worked out so perfect for my transplant. with, the amount of time they spent in there, I don't think he was in there very long to get it taken care of. And it seemed like it was just yesterday, to me anyway. And then also, the time afterwards, I think I was like so happy to have that thing. I tried to do everything in 1 year, and yeah, broke my hand. I, tore up my shoulder a little bit. I did a lot of things a little bit too fast. But now at least I've settled myself down, and I'm just being a really good person, and I'm eating all the good food that I can. Yeah. Thank you.
Oh, yeah, I think we have some of your pictures here.
Yeah, I didn't know how to work it.
So that's us in clinic. See, aren't these so much better than the things you see on like normal websites? This is like great stuff, right? Great content. That's us in clinic. It's right after the surgery.